we are also interested in T-cell function, and what I think personally, as more from the clinical part of my work, is that with these kinase inhibitors, you can postpone the disease, you can treat patients for a long time. Two problems. First of all, you won't cure any patients until now. And second of all, and specifically when I'm from the Netherlands, and I think in Europe it's much bigger problem than in the US, it's unaffordable to give patients for years and years a drug that costs 75,000 euro a year. And so we need to come up with something smarter, both for the patient and both also for pharmacoeconomic ways. And if you look to the history of cancer and also for CLL, the only way we can cure patients, and we can do it already for more than 20 years, is giving an allogeneic stem cell transplantation, which actually learns that a T-cell mediated response to your leukemia cells is a very feasible way. The only problem is that it's extremely toxic if you take allogeneic cells, specifically for this elderly population. The interesting part is that we get now to the point that we can use autologous T cells for CLL to treat cancer, very effectively working in melanoma, in Hodgkin's disease with these checkpoint inhibitors, in acute lymphocytic leukemia as the CAR T cells, where you make a chimera of an antigen and put it in a T cell. But so far, all those therapies are much poorer, much less effective in CLL. And the reason is that those T cells have an acquired T cell exhaustion, acquired dysfunction. And a lot of the research we do now is to find out why exactly is this, where does it come from, why does it exist in CLL, and what are the ways to overcome that. And one of the ways we do now is we're looking at virus-specific T cells in CLL, because we can learn a lot from those, because it's very predictive. A lot of research has been done how those T cell responses are, and to comparing that from CLL patients to healthy controls, we are starting to learn what actually happens in those T cells that makes them dysfunctional. And the second part of what you're studying now is that we have some very preliminary clues that the immune metabolism in those T cells is actually disturbed. So they have a different way of using energy, of using fuel, and that probably predicts also why they get this dysfunction. And if we can find the culprit of that, and if we can repair this T cell dysfunction, then all those therapies like CAR T cells, like checkpoint inhibitors, like B-specific antibodies, CD3, CD19, or CD3, something else on a CLL cell, can probably be much more efficient, and would be very interesting if you go from a helicopter view, to give this kind of drugs after some kinase inhibitors, stop kinase inhibition, start the T cells to finish the job, and maybe you can cure or at least can postpone much longer the relapse.